NASH is part of a multi-system disease. When you make the initial diagnosis, unless in the pre-cirrhotic state, there is no urgency to jump to doing things just because you can. You have time, outcome rates are low. At that point, you start with weight loss, consider optimizing the cardiometabolic and renal risk profile. Statins, fibrates, saroglitazar may or may not be relevant depending on what it is. Use of GLP-1, SGLT2s are already going to become first line, particularly if you already have type 2 diabetes. Now, because many of these may have benefits on NASH, there's no reason to add additional therapies. You continue to follow the patient and reassess at some point. Those who have residual active disease with significant fibrosis, then you bring in targeted therapy for NASH. Particularly, I think the F3 is going to be the sweet spot for pharmacological treatment, because there you start seeing outcomes. You can make a difference within 5 years in terms of patient outcomes, and where the disease still can be modified. F4 has been very difficult to move. Pretty much all the trials in F4 have failed, in my view, to date. And then, of course, you reassess as you go along. I thank you for your attention.